As a reminder, this is the MDM grid which determines the final E&M CPT code for an ED visit. The CPT codes are seen on the left from 99281 to 99285. In the last video, we discussed the first column, the number and complexity of problems addressed, or COPA or NCOPA. In this video, we'll discuss the second column, amount and or complexity of data to be reviewed and analyzed, also known as data. As you can see, in a level 4 and 5 chart, the data column is divided into 3 categories. Let's discuss each category in more depth. Category 1, tests, documents, or independent historians. The first subcategory is review of prior external notes from each unique source. This means that you should document when you review any document that originated from outside of your emergency department, such as discharge summaries, urgent care notes, nursing home notes, review of prescription drug monitoring programs, etc. In fact, reviewing notes from other emergency departments within your hospital system actually counts towards this category. Interestingly, neither CPT nor CMS policy indicate a documentation standard for this category, but, quote, outside records reviewed is probably not enough. You need to be a little more specific, such as, quote, I reviewed a discharge summary from last week, or even better, quote, I reviewed a discharge summary from last week which showed that the patient was admitted for chest pain and had negative troponins and a negative stress test. The next subcategory is review of the results of each unique test. This one's a little confusing, but it means documenting the review of any tests, such as labs or imaging, that again came from outside of your emergency department, such as urgent care, another emergency department, nursing home, etc. So if your patient was transferred from the nursing home without any paperwork that indicates the reason for the transfer, but has some lab work like a low hemoglobin, just document that you reviewed the labs. The next subcategory is ordering of each unique test. Simply ordering a test counts here. You don't need to mention that the interpretation of the lab test. It is assumed that you interpret all the tests you order. For example, a CBC and BNP count as 2 separate tests, and it's assumed that you will interpret these tests when they return. And this information is often pulled into your note by your EMR, so you don't have to document anything more for this requirement. On a side note, you also get credit for considering a test but ultimately deciding not to order the test. Most commonly, this will be avoiding a CT scan when using a decision rule such as Canadian head or C-spine rule, PCARN rule, etc. Of course, you must document the decision making here. The next subcategory is assessment requiring an independent historian. This means you should document when you get additional history from anyone else but the patient. EMS, spouse, caregiver, parent of a child. EMS is the clearest example here since they should provide some additional history such as vital signs, glucose, accident details, etc. But notice I said parents of a child. Yes, parents of the child counts. Therefore, most pediatric visits will satisfy this category since usually you obtain some history from the parent or caregiver, and it's virtually guaranteed to get credit here if the patient is under 2 years old. Note that an interpreter does not count here. You can remember this by the fact that they are not providing additional history, they're only translating a language. Finally, you should absolutely document the source of the history, but thankfully, you are not required to document the reason that an independent historian was utilized or to document which elements of the history were obtained from the independent historian. If you haven't been listening closely, now is the time to focus because the next 2 categories are super important. Category 2, independent interpretation of tests. The wording here is confusing again, but you get credit for any independent interpretation of a test that will eventually be interpreted by another physician. Essentially, this will be plain films and EKGs as long as your ED is not currently billing for EKG interpretations already. Please use independently interpreted, not just interpreted. Using the phrase independently interpreted makes it crystal clear to anyone reading your chart that you did the interpretation. Burn this phrase into your head. You do not need to have an official radiology report, you just need to prove that you looked at the EKGs or images. I will note that you can use this category towards an independent interpretation of a CT scan or a radiology performed ultrasound, depending on your skill set, experience, and comfort level, but it's much less common. POCUS exams are typically billed separately, so they are not counted towards this category or else it will be double dipping, billing for the CPT code associated with the POCUS exam, as well as increasing the complexity of your chart. Also, it does not matter if you interpret the test before or after the official report comes out for the EKG or plain film. One note is that for an EKG interpretation, you need to document at least 3 elements of the EKG. As an example, I always say, quote, EKG has been reviewed and independently interpreted by myself, which shows normal sinus rhythm at a rate of 60, normal axis, no ST changes, QTC 450. Or if a patient presents with dyspnea and I look at their chest x-ray, I would document, I independently interpreted the patient's chest x-ray and there was no evidence of pneumonia or pneumothorax. Finally, we get to category 3, discussion of management or test interpretation. This means that you should document the discussion of management of the patient with any external healthcare professional. Most people assume that it's a consultant or radiologist or primary care doctor, which is correct, but then forget about the discussion with the hospitalist for admission. For every admission, after I talk to the hospitalist, I write, quote, discuss management with the hospitalist who will accept the admission. This does not count for sending messages in the electronic medical records or discussing care with the family. If you look again at the grid, you need 2 out of 3 categories for a level 5 chart. You can see how a patient you admitted for chest pain, where you ordered a CBC, BMP, troponin, EKG, chest x-ray, which satisfies category 1 since you ordered 3 different tests, could be coded as a level 4 chart if you did not document the independent interpretation of the EKG or chest x-ray or document the discussion with the hospitalist. In the next video, we'll discuss the least clear and most misunderstood portion of the MDM, risk. Please post any questions in the comments and I will try my best to answer them.